Bismillahirrahmanirrahim. Assalamu alaikum class. This is your course instructor, Dr. Ghulam Fatima. And as you know, I am your course instructor for the subject of neurological physical therapy. So today we are going to discuss a topic that was discussed as one of the very basic topics in the neurological physical therapy, that how you are going to perform the sensory examination of a patient. So sensory examination, as you know, that we can divide your functions as sensory as and motor. In the first part, we'll discuss the sensory examination. In the next part, we will discuss the motor examination. So starting with the sensory examination, today we are going to discuss that how we can check the higher mental function or the executive functions of the brain. And in that we'll see how can we check the attention, how can we check the memory, how are we going to check the visual acuity and hearing of the patient, and how we are going to check the arousal of the patient. And these are very crucial for the neurological physical therapy patients, because these are the main functions that are disturbed in a result as a result of some neurological incident. So this is very important to check all these things. So we will cover all these things in today's lecture. So first of all, we need to know what is meant by sensory integration. Actually, sensory integration is simply how your brain is going to organize, and how your brain is then going to interpret, and then how your brain is going to use that sensory information. As you know that at a particular moment you are getting so many sensory stimulus from your environment. Like here, I am getting some hearing stimulus from this fan. I am getting some light stimulus. I am getting some background music stimulus. But my brain can't focus on each and every stimulus. So my brain has to focus on particular stimulus that need to be given attention at a particular moment. So as Rumi said that a part of knowledge is to know what to ignore. So that is how our brain functions, that it integrates and it prioritizes the sensory information, and it then interprets and decides that to which sensory information it needs to respond and which sensory information doesn't need any kind of response. So this process, that like receiving and then interpreting and giving it a meaningful meaning, and then using that sensory information, is a part of your brain and your higher mental functions. So, of whatever level you are going to perform a sensory examination, all the sensory examination is fortunately or unfortunately dependent on patient response. So if your patient is not alert, if your patient is not fully conscious, if your patient is not in um, optimal mental status, then this is not possible that his response is reliable. That's why the first part of sensory examination is to check the mental status of the patient and check the cognitive functions of the patient, and that will tell you either the sensory examination we will be conducting later on is reliable or it is not reliable. So we can divide the mental status examination in two categories. The first is in which you check the patient's arousal level, you check the attention span, you check the orientation, and you check the cognition. All these are executive functions or higher mental functions that need your to be working at its optimal for your sensory examination to be reliable. And then in the next part of this, you will be checking the memory, hearing, and visual acuity of the patient. So these are the categories that I used in that case. So coming towards the arousal, first of all, we will check that how we are going to check the arousal of the patient. So what is meant by arousal? Arousal is simply how physiological ready you are to respond, and how physiologically ready your systems are for the activity. This is called the arousal. Um, it got 5 stages, and you have to label patient according to these stages, and that will tell you that either the sensory examination of the patient is reliable or not. The first stage is called alert. When the patient is fully awake, attentive, he is able to respond you properly, and his interactions with you and his responses are normal and very appropriate, and he's answering you in a very appropriate manner, then the patient is called alert. Just like in a classroom, if you are alert and listening to the teacher and you are attentive, this will be considered as alert. The next stage, which is a bit lower than the alert, is lethargic. Now, you can to make you people understand. You can consider as like you are in a class, but after 45 minutes of a lecture, you are feeling very sleepy. So that is a condition that can be labeled as lethargic, when you will be appearing drowsy, and if the teacher is not stimulating you again and again and not interacting with you, you can fall asleep at any moment. And as a result of that, your interactions may get diverted. Sometimes you even don't know what the teacher is talking about if a question is put on you. So in that case, obviously the patient will have difficulty on focusing or maintaining attention on a particular question or task you are asking the patient. So in that state, the patient is labeled as lethargic. But in both these stages, alert and lethargic, we'll consider the sensory examination a bit reliable. So these are two stages where we can perform sensory, although the most reliable will be if the patient is totally alert, and lethargic is less reliable as compared to alert, but still it is acceptable. The next three stages, these are quite difficult because the patient response is not reliable in these stages. The next stage, which is the third stage, is called abdulate. To make you understand, you can consider it like you are sleeping and you are in the mid of the night, you are sleeping and someone tries to awake you and you suddenly awake and you don't know where you are and what time of a day it is, and you will be most of the time you will sleep again if you are not continuously stimulated. So same is the case here. In abdominal state, the patient is very difficult to rouse from the sleepy state, and even he is awake, then he will be confused, he will be not oriented that where is he, what time is it, and he will fall asleep again if you are not continuously stimulating the patient. And obviously if you are asking something and it will be very difficult for the patient to respond in a appropriate manner. So the next stage is stupor, which is also called semi-coma. This is the stage where patient is semi-coma. You know that it comatose, but this is not deep coma. The patient will respond, but only when very strong and noxious, painful kind of stimuli is given to the patient, and he will return to that unconscious state the moment you will stop the stimulation. So even when the patient is awake, he will not be able to interact with you. He may open his eyes and look at you, and he may show some movement or may make some verbal noises, but the proper interaction with the PT is missing. So the next stage is coma, which is deep coma, in which the patient cannot be aroused by any kind of stimulation, and that is called coma or deep coma. And in that case, sometimes the reflex motor responses are present, and sometimes they are even absent, and it depends on what areas of the brain are damaged or what area of the brains are not working in the current situation. So these five stages are there to check the arousal level of the patient, and even if the patient is in alert or the patient is lethargic, then you can perform the sensory examination. If the patient is up to in stupor or coma, it is very difficult to perform a sensory examination. It will be fruitless to perform a sensory examination. You will have to wait for that. The next domain is attention. And in other words, we say attention span or concentration span. That is required here, that how long the patient can concentrate on a particular task without being distracted. So simply attention is their responsiveness to a stimulus or task without being distracted. And if the patient is distracted and looking at here and there, it simply means that patient's attention is not that much optimal and patient is not attentive. So simply to check your attention, you will ask the patient to repeat simple items, and you will give progressively challenging list. Like you can start with simply two or three. So you can ask the patient to repeat a word cat, and patient will repeat like PAC, cat. This is very basic. From that onward, you can say the patient to repeat a word like book. Now he will say like KOOB. So it needs a very little attention span. But to start with, you can start with that, and after that, you will ask the words like bottle, garden, and orientation. Any kind of words can be asked, and these can be some numbers like 3, 2, 4, 5. The patient will have to repeat. Um, I don't remember myself. So this is how you can check the attention of the patient. So the next domain is orientation. Orientation simply is the how oriented is the patient. It is checked in three domains. The one is person, the second is time, and third is place. This is a very common practice जब के ऐसे हॉस्पिटल में न्यूरोलॉजिकल पेशेंट्स होते हैं उनसे पूछा जाता है कि भी आपका नाम क्या है, आप कहाँ पे हैं इस वक्त, दिन का कौन सा हिस्सा हुआ है इस वक्त. So these are the very basic questions to know that either patient is aware of the time, person, and place, or patient is totally disoriented. So this is a part of checking orientation. So as we check orientation of three domains, time, person, and place, we'll label is that oriented into three. We write down is oriented into three if the patient is oriented and not totally normal and oriented in time, person, and place, all of the things. If the patient is not fully oriented in one or more domains, like patient knows that what is his name and where he is, but he is not aware that what time of day is it, he is not aware that it is morning or it is evening, then we can write this like patient the disorientation domains of disorientation are within the parenthesis, just like this, like oriented into two. It means the patient is oriented in person and place. Patient know who is he and where he is, but he is disoriented in time. It doesn't know what time of a day is it. Or on the other case, where the patient is only oriented in one domain, like he remembers his name, he knows who he is, but he doesn't know what time of the day is it or where he is at the moment. So this is the way we check the orientation of the patient, and this is the way of documentation, how orientation is documented in your reports. The next domain is cognition. As you are very well aware of the layman meanings of this term, that how you understand the things, all these are known as cognition. But actually, it includes two things. It includes your awareness, and it also includes your judgment. You are aware of one thing, and the second part of cognition is your judgment, because being human nature, being given and gifted with our wisdom, we always we always attach a part of judgment with everything, with every part of knowledge we have. So simply cognition is actually a broad term which encompasses your awareness as well as your judgment. So actually to completely encompass all the areas of the cognition dependent function, it is further divided into three areas. First is fund of knowledge. We'll discuss these three one by one. One is fund of knowledge, second is your calculation ability, and third is your proverb interpretation. So fund of knowledge is simply sum of total of an individual's learning and experiences in life. Obviously, these are highly variable. Like एक बंदा है जो पढ़ा लिखा है, PhD डॉक्टर है, उससे आप उसके नॉलेज के लिए फंड ऑफ नॉलेज जाने के लिए जो क्वेश्चन करोगे वो किसी और लेवल के होंगे. और एक सिंपल बंदा जो बिल्कुल कभी स्कूल नहीं गया, जो मजदूर है, उससे आप जो है या गांव से है और जिसके पास कोई ऐसे टीवी ऐसे मीडिया नहीं है दुनिया से कनेक्ट होने का, उससे आप जो क्वेश्चन करोगे वो बिल्कुल डिफरेंट होंगे. तो यू हैव टू सी लाइक इफ बीइंग अ थेरेपिस्ट, इफ माय पेशेंट इज अ थेरेपिस्ट, आई विल आस्क द पेशेंट regarding some kind of education or some kind of like general knowledge questions I can ask. But if the patient is totally illiterate, I'll like have to drop down my questions to very basic and very simple levels. So fund of knowledge varies according to the patient on life experiences and learning, and patient's on personality. So coming towards the calculation ability. Obviously, as you know, calculation ability, it will check your mathematical abilities. How, as you know, that even a small kid is able to calculate the money he is having in his pocket. So actually, calculation ability, and even the most the people who are like merchants, who are like some kind of businessmen, but they are totally illiterate, still they will be very good in the calculation. The calculation is a very basic kind of knowledge in mathematics. Basic mathematics is a very basic knowledge that most of the people have, although their background is mathematical or not. So here we'll try to examine foundational mathematical ability. So there are two associated terms in after your examination. Sometimes you may find that patient is not able to calculate, like even very basic thing that yeah, 7 plus 3 is equal to, and the patient is unable to answer. It simply means acalculia, which means that patient is unable to calculate, inability to calculate. And sometimes there is dyscalculia, where the patient has difficulty in accomplishing calculations. So in dyscalculia, like you say 326 and 146 and equal to, and patient has to take a lot of time and patient is doing that incorrectly, so that is actually will be considered as dyscalculia. So you can take this examination verbally, like I ask you to like plus 22 plus 11, you will ask 33. So it can be a form, or you can take it in the written form if the patient is like in that condition and patient is not illiterate, then you can go for the written format too. So simply you will ask the patient to perform simple mental exercise of a series of calculation. You will start the very basic, like 7 plus 2, 11 plus 22, from very basic, and then you can like exceed towards the more difficult calculation. So this is the mechanism of all the sensory examination and all the motor examination, that you will start from the very simple, very basic, and then you will build up upon that and you will go towards the most complex task and more complex questions. The next is proverb interpretation. As you all know, proverb जिन्हें आम जुबान में हम मुहावरे भी कहते हैं, ठीक है. पेशेंट बात कुछ और रही थी, उसका मतलब कुछ और होता है. तो you have to see that either the patient is able to understand the actual meaning of that phrase. So that is the proverb interpretation, and obviously this is a very sophisticated cognitive function, and patient has to extract the meaning of that proverb. Now, in our local setting, obviously you will encounter the patient who are most of the time Urdu speaking. So you can use the proverbs like "Bhais ke aage teen bajana" ya "Khyasiyani billi khamba noche, basi kadi mein bala na." You can use any of these proverbs, and you need to see that either the patient is able to answer them correctly, or either the patient is able to understand the deeper meanings associated with these proverbs. So that is a part of proverb interpretation. So here the first part of our higher mental function mental status examination is finished, and we check the patient's at arousal level, patient attention level, patient's calculation ability, and patient proverb interpretation, and the patient's fund of knowledge was tested in that. So these are the all very basic kind of things which are used to check the mental status of the patient. So next part of our mental status examination was to check the memory, hearing, and visual acuity of the patient. Simply memory, hearing, and vision will be tested in this. So starting from the memory, simply you will check the memory and divide the memory testing in two forms. One is the long term, or which is also called remote memory, where you will ask the things which were in the kind of years back ago. What is the date and place of birth? Which school the patient attended? What if he is married? What is the date of marriage? How much marks he got in the matriculation examination? And you can ask then when the Pakistan was made, and or date of birth of the Qaeda Azam, date of birth of Sayyid Ahmed Bal. All these can be asked as a test to check the long-term memory of the patient. You can ask either the personal information that can be like some dates and anything, and you can ask about some general information. So both of these are actually used to check the long-term and remote memory of the patient. The second type of memory, we need to check the short-term memory of the patient. So in that case, we will provide the patient with simply a few series of words or series of number or a short sentence, and patient will have to remember that and report that after 5 minutes, and then after more time, after like half an hour. Now the patient, like you can provide the terms like you ask the patient to currently remember that you just said a yellow flower, a red car, or a blue sky. So patient have to remember the words in the same sequence, and he will repeat this after a few minutes. Like you will ask the patient to recall the list after 5 minutes, and that will be telling you that is a normal memory function, short memory. And you will again ask the patient to revise after half an hour, and if patient can remember at least two of the items from the list, and even if he forgets the others, then he is in the normal, his memory is normally functioning. So this is the way how can we check the long-term memory and short-term memory of the patient. Next, we are going to discuss the hearing, how we are going to check the hearing of the patient. Actually, no special test and no special method is there device to check the hearing. This is simply an ongoing process that is inbuilt in your testing, like asking the questions or asking the information in the which was a part of your previous examination, previous sensory examination. You can guess what kind of hearing is the patient is there. You will by only observing the patient response. So you will be just keen and you will observe the patient's response, and in certain cases you can like alter your voice volume and tone and see how the patient response is influenced by that. So simply hearing is checked during the other examination part, and there is no special equipment. When if someone is short of hearing, and if someone is hard of hearing, they can easily you can easily like guess that patient is not able to listen to you in a normal voice volume. So the last part of this examination is check visual acuity. Visual acuity simply means how clear the vision is. So as all of you might have visited some ophthalmologists to get your eyesight checked, there they make you sit on a chair or a stool, and there is a chart in front of you, and you have to read some alphabets on the chart. So that chart is called the Snellen chart, and usually it is mounted on the wall. And but in the case where you are testing some kind of neurological patient, you may have to check like some kind of handheld cards, if you are going to use that on the bedside for indoor patients, or you may need to use some phone applications. Typically the Snellen chart, which is mounted on the wall, that is at a distance of 6 meter or 20 feet. But if you are using such handheld like Snell chart, or you are using some kind of phone application in your hand, then 1 meter of distance is usually considered optimal. So this is how a Snellen chart look like. They are alphabets starting from the biggest and coming towards the lowest. So actually this is the where we consider the most normal. If the patient can read this line, we'll consider the patient normal, and we'll label it by 6 by 6. We can say that is from the meter 6 by 6, or if you are using feet 20 by 20, it simply means that perfect eyesight. So we can use both of these for your cases. The next step is to check your peripheral field vision. You always have field visions. We have 4 quarters and we have field visions, 4 field visions. So you have to check that. Simply you sit in front of the patient with your outstretched hand and your index finger is extended, and you will bring it towards the mid of the eye. Okay, actually the procedure is that you will sit in front of the patient, and this is the test is also for confrontation method, and you will cover your one eye, and the patient will also cover the opposite eye, or and you will compare your field eye field with the patient's eye field. You have to cover the eyes of the same side. You and patient will cover the eyes of the same side, but if you will consider in the terms of right and left, then your and patient's eye will be opposite, but actually you have to check the field. So you will cover the eye, and then you will like bring your fingers, moving fingers towards the front, and you will ask the patient to just tell you the point he is able to see your finger, and then from the other field, and then from this side, and then from this side. And you will ask the patient to let you know when and you will compare either the time you are able to see your moving finger and the patient is able to see your moving finger are same or not. If the patient is having, sometimes the problem is only in one field or only half of the eye field is gone, so the patient won't be able to see your finger in that field, and he will only be able to see when it is clear near to your mid of the center of your eye. So you have to like differentiate, and you have to like you have to monitor, and you have to document the differences between right and left visual fields very carefully. So these are the actually the visual fields. You might be able of that. This is the central field, and this is your superior nasal quadrant that will be towards your nose. This is superior nasal quadrant. If we divide our say eyeball in four parts. So this one towards above one towards the nasal, this is superior nasal quadrant, and this is inferior nasal quadrant, and towards your temporal side, this is superior temporal quadrant, this is inferior temporal quadrant, and then coming towards the opposite side, towards your left side, this is superior nasal quadrant, this is inferior nasal quadrant, this is superior temporal quadrant, this is inferior temporal quadrant. This is very easy to remember because जो नोज साइड पे उसको नोज सुपीरियर और इंफीरियर नेजल में करते हैं, जो टेम्पोरल साइड पे उसको सुपीरियर और inferior temporal में divide करते हैं. So these are very easy to remember. So this is the complete picture. If your all the fields are okay and there is no defect in any field, this is the complete picture how it looks like. This is called bitemporal hemianopsia. Hemianopsia simple means that half of hemi means half. Hemianopsia means half of the visual field is not working, and bitemporal hemianopsia means that the temporal side of visual field of both the left side and right side, so both are not working. Only the nasal fields are visible for this person. This is bitemporal hemianopsia. Opposite to the previous one is binasal hemianopsia. In this kind of problem, the nasal fields are not visible and patient is able to see only the temporal piece. This is called binasal hemianopsia. This is left homonymous hemianopsia. Homonymous means that same. So in left homonymous hemianopsia, the both sides of one side of your temporal field and the other side your nasal field is missing. So this is left homonymous hemianopsia. Opposite to that, this is right homonymous hemianopsia. That for your right side of the eye, your nasal field, and on the opposite side your temporal field are missing. So these are the defects in the fields that are observable. After that, there is a term which is called depth perception. Depth perception is simply a term that if you are having two things in your hands, like say I have these two things, that I can easily guess which is in front and which is behind. You can take three things at one level and ask at eye level. One level, same level, and at eye level. Ask the patient to pick up the one which is the behind. The patient will pick up this. Or you can say the pick up the one which is in front, and the patient will pick up this. So this is a method. How can you check the depth perception? Simply, or you can place your fingers one another, and patient will you will ask the patient to touch the one which is behind, and then or oppositely you can ask the patient to touch the one which is in front. So this is the method. How can we check the depth perception? So that's all for the lectures today. We'll simply discuss the how can we check as a preliminary part of your sensory examination. We'll be checking your mental status, and you will check your arousal of the patient. You will check patient's attention. You will check patient's calculation ability, proverb, interpretation, and patient's span of knowledge. And you will check all these are part of cognition. Then you will check patient's hearing, you will check visual acuity, and you will check the short-term and long-term memory. So that's all for the lecture today. I hope that it will be useful for you. In the next lecture, we will be discussing the other parts of the examination for your sensory and motor systems.